Welcome to the chapter on neurology. Before we get started, I'd like to take a second and mention that much of the neurophysiology for Step 1 heavily relies on a strong anatomical understanding of the nervous system. This means we'll be covering a lot of anatomy throughout this chapter. Please recognize that you will likely have to take time to pause the videos and memorize a lot of material due to the nature of the content. Our goal is not to focus on memorizing the anatomy with you, rather it's to provide you with concise figures and tables that will make memorization easier, and then we'll focus on the important physiology and integrate the material by doing many practice questions. In the first section, I will be discussing the cerebral hemispheres and some of the major landmarks in this region. Let's get started. This is figure 8.1 from your text, which is an anterior view of the brain. First, let's go over the major grooves of the brain. These are also called fissures or sulci, and there are 4 major grooves that you need to be familiar with for Step 1. These include the longitudinal fissure, the lateral sulci, the central sulci, and the parieto-occipital sulci. Let's look at each of these now. The central groove, which you can see right here, separates the 2 hemispheres and is called the longitudinal fissure. In this image, you can also see the lateral sulci right here, which separates the inferior temporal lobes from the superior frontal and parietal lobes. So the temporal lobe is this region right here, and we can clearly see the frontal lobe right here. However, it's difficult to see the parietal lobe, so we'll look at that later in figure 8.2. So again, the lateral sulci separate the temporal lobes from the frontal and parietal lobes. In this image, we can see the cerebellum right here and the brainstem. Okay, let's look at a lateral view of the brain. This is figure 8.2, which is a lateral view of the brain. This is posterior and this is anterior. Again, this is the lateral sulcus right here, and it can be easily seen from this lateral view. We can also see the central sulcus right here, which separates the frontal lobe from the parietal lobe. Finally, the parieto-occipital sulcus is hard to see in this image, but it's approximately right here, and it separates the parietal lobe from the occipital lobe. If we look at a sagittal view of the brain, we can more easily see the parieto-occipital sulcus. As a quick reminder, a sagittal view just means we've cut the brain in half through the longitudinal fissure like this. And we're looking at the inside of the brain from the side, so this is an eye, we'd be looking at it from this angle. Okay, with this in mind, let's look at figure 8.3. This is figure 8.3, which is a mid-sagittal view of the brain. Again, this is anterior and this is posterior. In this image, we can clearly see the parieto-occipital sulcus right here. We'll cover more of the anatomy from this view later, but for now, let's see what your text says. So again, the major grooves of the brain include the longitudinal fissure, the lateral sulci, the central sulci, and the parieto-occipital sulci. Okay, let's return to figure 8.2 and review the major lobes of the brain. As we can see, this is the frontal lobe, and just posterior to it is the parietal lobe. Inferior to the frontal and parietal lobes is the temporal lobe. Finally, the most posterior lobe is the occipital lobe. Again, the 4 major sulci we covered are helpful in clearly distinguishing between the different lobes. Okay, with this basic overview, let's talk about some of the important functions of the different lobes. Generally speaking, the frontal lobe is responsible for judgment, concentration, orientation, and primitive reflexes. Aside from this, there are 3 major gyri in the frontal lobe that you need to be familiar with. The first is the precentral gyrus. The name comes from the fact that this gyrus is directly anterior to or in front of the central sulcus, which is right here. Hence the name precentral gyrus. This is also sometimes called the primary motor cortex, as we can see in parentheses. And this is because this gyrus is the location of all of the upper motor neurons that are responsible for movement. We'll talk about this more later, but essentially this single gyrus is what allows us to move. If the primary motor cortex is damaged, then the patient will experience complete contralateral paralysis. We'll talk about this more later, but it's important to know that the tracts from the motor neurons decussate or cross over to the opposite side of the body. This is why when the left primary motor cortex is damaged, the right side of the body is affected. Okay, with this in mind, let's do a question. What symptoms should you suspect in a patient who has damaged the left primary motor cortex? So as we just discussed, the patient would be unable to move the right side of his or her body. This would include the right side of the face, the right arm, and the right leg. So right-sided paralysis. Again, this is because the tracts from the upper motor neurons from the primary motor cortex decussate or cross over to the opposite side of the body. Okay, the second important gyrus that you need to be familiar with for Step 1 is located right here. This is called the frontal eye field. You need to know that it's anterior to the primary motor cortex and it's associated with eye movement. It's important to know that if the frontal eye field region is damaged, then the patient's eyes will deviate to the ipsilateral side. Okay, with this in mind, let's do another question. How would the left and right eyes be impacted if the left frontal eye field region was damaged? So the left frontal eye field region. So both eyes would deviate to the left. Remember, damage to the frontal eye field region results in deviation of both eyes to the ipsilateral side. Because the left frontal eye field region was damaged, we know that the eye should deviate to the left. The last gyrus that you need to be familiar with in the frontal lobe is located right here. This is called Broca's area. Notice how it's anterior to the primary motor cortex and superior to the lateral sulcus, which is right here. You also need to know that Broca's area is responsible for what some examiners like to call motor speech, which you can see in parentheses. We'll talk about this in more detail later in the chapter, but this just means the patient cannot speak, but the ability to understand what others are saying is intact. Okay, let's see what your text says. So again, there are three major gyri in the frontal lobe that you need to be familiar with. These include the primary motor cortex, the frontal eye field region, and Broca's area. The primary motor cortex is the location of all of the upper motor neurons that are responsible for movement. The frontal eye field region is associated with eye movement, and Broca's area is responsible for motor speech. Okay, let's move on to the parietal lobe. Again, the parietal lobe is right here. It's posterior to the central sulcus, superior to the lateral sulcus, and anterior to the parieto-occipital sulcus. There are two important gyri in the parietal lobe that you need to be familiar with for step one. These include the postcentral gyrus and the angular gyrus, which isn't labeled in this image, but it's about right here. The postcentral gyrus is also called the primary sensory cortex, which we can see in parentheses. And this is just posterior to the central sulcus. This is very similar to the primary motor cortex, but instead of housing the upper motor neurons that are responsible for movement, this cortex is responsible for processing sensations throughout the body. This would include temperature, vibration, proprioception, pain, and so forth. We'll talk about this more later, but it's important to know that the sensory information also decussates or crosses over to the opposite side of the body. This is why when the left primary sensory cortex is damaged, the right side of the body is affected. So for example, if the left primary sensory cortex was damaged, what symptoms would you expect in a patient? Well, the patient would lose sensory information on the right side of the body, so he or she wouldn't be able to feel pain, temperature, vibration, and other sensations on the right side of the body. Okay, the next important gyrus in the parietal lobe is the angular gyrus, which we pointed out already. And the angular gyrus is associated with performing mathematical calculations, writing, distinguishing left from right, and identifying fingers on the hand. If the angular gyrus in the dominant parietal lobe is damaged, then the patient will be unable to perform these functions, which results in a syndrome called Gerstmann syndrome. It's also important to know that damage to the non-dominant parietal cortex and the dominant parietal cortex will result in different symptoms. If the non-dominant parietal cortex is damaged, then the patients will experience something called hemispatial neglect. Let me write that out. Hemispatial neglect. This is a disorder where the patient has a deficit in awareness to one side of space. For example, if the right parietal cortex is damaged, then the patient will be unable to notice things occurring in the left visual field. Okay, let's do a couple questions. A 64-year-old right-handed female is brought to the emergency department after the sudden onset of tingling and burning on the right side of her body. Upon examination, there is a complete loss of sensation of the right arm. What region of the brain is damaged? Okay, let's break down the question. With most neuro-related questions, you'll notice the question stem will often mention if the patient is left or right-handed. This is important because it tells you what is the dominant hemisphere in the patient. In this patient, we can see that she is right-handed, which means the left hemisphere is the dominant hemisphere. Also notice that the patient developed somatosensory abnormalities, which progressed to a complete loss of sensation of the right arm. We're asked what region of the brain is damaged. Because this patient is experiencing sensory deficits on the right side of the body, we can deduce that the left parietal lobe must be involved, specifically the left primary sensory cortex of the parietal lobe. So left primary sensory cortex. Remember, all sensory and motor information crosses over to the opposite side of the body. So if the right side of the body is affected, then we know that the left side of the brain must be involved. Okay, let's extend this question a little more. If the entire parietal lobe was involved, what other symptoms would you suspect in this patient? Okay, so we know that the left parietal lobe is damaged, and we also know that this patient is right-handed, so her left hemisphere is the dominant hemisphere. So left is dominant. Recall that when the angular gyrus of the dominant parietal cortex is damaged, the patient can develop Gerstmann syndrome. Because the question states that the entire parietal lobe was involved, and we know that this is the left or dominant hemisphere, we can deduce that the angular gyrus must be involved. In this case, we'd expect the patient to have the symptoms associated with Gerstmann syndrome. Remember, symptoms of Gerstmann syndrome include the inability to perform mathematical calculations, the inability to write, the inability to distinguish left from right, and the inability to identify fingers on the hand. Okay, let's see what your text says. So again, there are two important gyri that you need to be familiar with in the parietal lobes. This includes the primary sensory cortex and the angular gyrus. Again, the primary sensory cortex processes all the sensory input from the contralateral side of the body, and the angular gyrus is involved in performing mathematical calculations, writing, distinguishing left from right, and identifying fingers on the hand. It's also important to remember that damage to the angular gyrus of the dominant parietal cortex results in Gerstmann syndrome, and damage to the non-dominant parietal cortex results in hemispatial neglect. Okay, let's move on to the temporal lobe. The temporal lobe is right here. It's inferior to the lateral sulcus, and anterior to the parieto-occipital sulcus. There are two important gyri that you need to be familiar with for step 1. These include the superior temporal gyrus and the fusiform gyrus. The superior temporal gyrus is right here, and it's just below the lateral sulcus. This gyrus contains two important regions that you need to know for step 1. This region here is the primary auditory cortex, which is responsible for processing auditory stimuli. Slightly posterior to it, right here, is Wernicke's area, which helps the patient comprehend what others are saying and also helps the patient speak in a logical manner. We'll talk about this more later. The fusiform gyrus cannot be seen very well from this angle, so we'll talk about this more in a second when we're looking at a coronal view of the brain. In addition to these two gyri, you also need to be familiar with the hippocampus, the amygdala, and the uncus of the temporal lobes. In order to see these, we'll need to look at the brain from a different angle. Again, this is figure 8.1, which shows an anterior view of the brain. If we cut the brain sagittally, slightly laterally to the midline, like this, and if we look at the brain from this angle, we can more easily see the hippocampus and the amygdala. This is figure 8.4 from your text, which is a lateral view of the limbic system and the basal ganglia. And again, this is a sagittal section of the brain, just lateral to the midline. Here we can see the thalamus and several important components of the basal ganglia, which we'll talk more about later. We can also see the hippocampus as it projects anteriorly, and at the tip of this region is the amygdala. It's important to know that the hippocampus is responsible for memory formation, and the amygdala is associated with emotions and decision-making. Both of these structures are located in the temporal lobes of the brain and are an important part of the limbic system, which we'll cover in more detail later. Okay, now let's look at a coronal view of the brain and identify some of the important structures we've been talking about from a different angle. Recall that a coronal view is achieved by cutting the brain like this and looking at the brain from this angle. This is figure 8.5, which shows a coronal view of the brain. The lateral sulcus is right here, so the temporal lobe is the region inferior to the lateral sulcus, right here. The hippocampus is right here, and the amygdala is right here. The uncus can be seen right here, and it projects medially. You can see it a little better right there because it's not covered up. It's important to know that the uncus is associated with seizures, and it can also compress the third cranial nerve during an uncal herniation. An uncal herniation just means the brain is being compressed, which causes the uncal regions to press on the brainstem. The fusiform gyrus is right here, and it's just between the hippocampus and the inferior temporal gyrus. It's important to know that the fusiform gyrus is responsible for facial recognition. Okay, with this in mind, let's do a question. A 63-year-old male had a stroke 1 week ago, and he no longer recognizes his wife or children when they enter the room. What region of the brain was likely damaged? In this question, you need to know that the 63-year-old patient can no longer recognize faces. This is also called prosopagnosia, and this is caused by damage to the fusiform gyrus, as we just learned. Okay, let's see what your text says. There are 6 areas that you need to be familiar with in the temporal lobes for step 1. These include the primary auditory cortex, Wernicke's area. Remember, both of these are in the superior temporal gyrus. The hippocampus, which is responsible for memory. The amygdala, which is associated with emotions and decision-making. The fusiform gyrus, which is responsible for facial recognition. And the uncus, which is associated with seizures and can also compress the third cranial nerve during an uncal herniation. Okay, let's talk about the occipital lobe. Again, this is figure 8.3, which is a mid-sagittal view of the brain. This is anterior, and this is posterior. Recall that the parieto-occipital sulcus separates the parietal and occipital lobes. For step 1, it's most important to know that the occipital lobe houses the primary visual cortex. Damage to the occipital lobe would result in visual impairments, which we'll talk about in more detail when we cover ophthalmology. Okay, now that we've covered all of the major lobes and important landmarks, let's move on to discussing the homunculus. This is figure 8.6 from your text, which shows the homunculus. The homunculus is a representation of the body superimposed over the precentral and postcentral gyri. This figure may seem confusing at first, but it's actually pretty straightforward. So it's a coronal view of the precentral and postcentral gyri, and there's a human body overlaying on top of the gyri. If you can memorize this figure, then you'll know what part of the brain is responsible for producing the movement and sensation associated with each part of the body. For example, this image shows us that the medial aspect of the gyri are responsible for producing movement and sensation in the legs, because there's a leg right here. As we move more laterally, we can see that the arm, the face, the tongue, and the upper GI tract are all represented by these regions of the precentral and postcentral gyri. Okay, so now we're going to do another question. A tumor originating from the medial aspect of the right parieto-occipital sulcus projects anteriorly, compressing the postcentral gyrus. What symptoms would this patient likely experience? Okay, for this question, let's pull up figure 8.3 so we can clearly see what the question is referring to. This is figure 8.3, which shows a mid-sagittal view of the brain. And again, this is anterior and this is posterior. From the question, we know that the tumor originates right here near the parieto-occipital sulcus. And we also know that it's projecting anteriorly, like this. As we can see, the central sulcus is right here, which means the post-central gyrus would be about right here. As we just learned, the medial aspect of the homunculus is responsible for producing movement and sensation in the legs. Because we know the tumor is only compressing the post-central gyrus, we'd expect sensation to be abnormal and movement to be intact. So in this case, we'd expect the patient to have sensory abnormalities affecting the contralateral leg. From the question, we know the right post-central gyrus is being compressed, so the patient would likely have sensory abnormalities affecting the left leg. So again, the right post-central gyrus is affected, which would result in sensory abnormalities of the left leg. Okay, let's do another question. A 70-year-old woman presents with paralysis of the right leg. What region of the brain is likely damaged? So this question is pretty straightforward. From the question, we know that the right leg is paralyzed, which should make you think of the precentral gyrus. This is because the precentral gyrus is responsible for movement. Let's pull up figure 8.6 so we can see what part of the homunculus is affected. So again, this is figure 8.6, which shows the homunculus. Recall that the precentral gyrus is responsible for movement, and the postcentral gyrus is responsible for sensation. In this case, the medial aspect of the precentral gyrus is affected. Because the patient's right leg is paralyzed, we can deduce that the left lobe is damaged. So again, the medial aspect of the left precentral gyrus is damaged. Okay, before we wrap up section 1, let's briefly discuss something called the internal capsule. Again, this is figure 8.5, which shows a coronal view of the brain. Recall that the precentral gyrus, or primary motor cortex, is the location of the upper motor neurons, which are responsible for movement. These neuronal cell bodies have axons that project down into the brain. So if we imagine that the precentral gyrus is right here, and these are all upper motor neurons, then their axons would move through the brain like this. This region here is called the internal capsule. And for step 1, it's important to know that the internal capsule contains axons coming from the primary motor cortex. So all of these axons right here. So if we were to follow the pathway of a single upper motor neuron, it would start in the superficial part of the brain, as I've demonstrated by these red circles, and it would move down through the internal capsule. Okay, let's look at a transverse section of the brain. This is figure 8.7, which shows a transverse section of the brain. Recall that a transverse section is achieved by cutting from the anterior part of the brain to the posterior part of the brain, such that we're able to view the brain from above. So this is anterior, and this is posterior. As we can see, the internal capsule is this region right here. It's important to know that the internal capsule is broken down into 3 parts, which can more easily be seen on this transverse section. We have the anterior limb, the genu, and the posterior limb. The anterior limb contains fibers from the basal ganglia, cerebellum, and other structures, but this isn't particularly high yield for step 1. For step 1, it's most important to remember that the anterior 2/3 of the posterior limb, so about right here, contains motor fibers or axons of the corticospinal tract. Corticospinal. We'll talk about this tract in more detail in section 2, but for now, just recognize that the anterior 2/3 of the posterior limb of the internal capsule is an important part of the pathway of the corticospinal tract. You also need to know that the posterior 1/3 of the posterior limb, so this region here, contains sensory fibers of the thalamocortical tract, which again we'll talk about later. Finally, the genu, so this region right here, contains motor fibers of the corticobulbar tract, which we'll talk more about in section 3.
Welcome to section 2 in neurology. This section will actually be split into 2 parts, and this is part 1. In this first video, we will be doing an overview of the spinal cord and the spinal cord levels. So let's get started. So here's figure 8.8 from your text. So let's identify the different locations that you need to know. This is just a very basic overview. So you've got the cerebrum, which is discussed in section 1 of this chapter. You got the pons, that's labeled here, as well as the cerebellum that you can also see right there. And then the brainstem is important in this region, which includes the midbrain, pons, and the medulla. And then you have the medulla, which becomes the spinal cord in this region here. And then you'll notice the enlargements. You have a cervical enlargement because there's a lot of nerves that are going to the upper extremities. And then here in the lumbar region, you have the lumbar enlargement because there are a lot of nerves that are going to the lower extremities. At the very end, you've got the conus medullaris. So this is just a basic overview so we can get started with the spinal cord. So now let's take a cross-section of the spinal cord and focus on that. This is figure 8.9 from your text. And so what's important to know is that the spinal cord conducts information from the brain to the periphery, or from the periphery to the brain. Sensations such as pain, temperature, and touch will come from the periphery in through the dorsal root ganglion, and then come in. There will be some sort of interaction here, but ultimately, whether it goes up through this region or this region, we'll get into the tracts in a moment. But what's important to know is that the information travels up in this white matter. And it does this at every spinal cord level. Something else I want you to make sure you understand is that this inner dark blue part is the gray matter, and this lighter part is the white matter. So now we will show figure 8.10 from your text, showing each individual spinal cord level. Notice how the white matter increases in volume as you go up. This makes sense. The sensory axons in the white matter collect as you move up. So here at the sacral level, you have sensory axons coming in and traveling up. And at the lumbar level, travel up, thoracic level, and the cervical level. So it makes sense that here at the top, in the cervical region, you have a lot more white matter. So on this left side in red, we demonstrated sensory information traveling to the brain. And now on this right side, we're going to talk about motor innervation. So motor innervation from the brain travels down the brain through the spinal cord and then sends information to the periphery. And it does this through peripheral nerves. Now motor axons from the brain heading to the periphery are part of the white matter, as I've demonstrated here. They also contribute to the decrease in white matter as you descend down the spinal cord. In other words, you're going to have more white matter at the top as you continually lose the nerves heading to the periphery. So it's consistent with what we've demonstrated here with the sensory nerves. There's going to be more white matter at the top and less at the bottom. So notice how each level of the spinal cord has a distinct appearance. So let's actually erase all this so we can take a better look at it. So it's very important to be able to recognize each of the 4 segments of the spinal cord. Notice how each spinal level of the spinal cord, whether it be cervical, thoracic, lumbar, or sacral, has a distinct appearance. So first, it's really important to just recognize that the cervical spinal cord has this wide appearance. You'll also notice that it has the most white matter, always right, most white. And then thoracic level has the least gray matter, but it also has a lot of white matter. So you get this interesting appearance with a lot of white matter and this just skinny looking gray matter. And then the lumbar and sacral look very similar. So it's really helpful to recognize that the lumbar, of course, is going to be larger than the sacral. In fact, the lumbar and sacral spinal cord levels are so similar that it's really not fair to ask you a question about identifying just the lumbar or just the sacral spinal cord level in isolation. In other words, you're really going to have to see both of them, both the lumbar and the sacral, and be able to compare the size in order to really understand what you're looking at. Because sometimes the lumbar spinal cord level can look a lot like the sacral spinal cord level. They both have a lot of gray matter and they've got the least amount of white matter. So you just need to compare them. Otherwise, just memorize the cervical and thoracic, and then memorize the lumbar and sacral together. So now let's talk about the pattern of spinal nerves as they relate to the vertebrae. So here's figure 8.11 from your text. So just remember that there are 8 cervical, 12 thoracic, 5 lumbar, and 5 sacral. We actually didn't show the sacral nerves here, so I'll just make sure that that's clear. So notice where each spinal nerve exits the vertebrae. The cervical nerves exit above their corresponding vertebrae. So here is C1, as labeled, the atlas, and you have the C1 spinal nerve will actually exit above that. So I'm drawing that in here. So I'll just write C1. And then you can see C2, which is labeled, and then the C2 spinal nerve will exit right above that. And this pattern continues until you get to C7. It includes C7. So if this is the C7 vertebrae, then right here is C7, exits above the vertebrae. And then C8 actually exits underneath. So then the pattern changes from here on out. So this pattern continues from T1 to the rest of the spinal nerves. So every spinal nerve below T1 will exit below its associated vertebrae. So let's say a patient gets in a car wreck and a radiograph shows that the vertebrae down through C6 have shifted anterior to the vertebrae C7 and below. What spinal nerve is likely damaged? So the radiograph shows that these vertebrae, C6 and up, have shifted anteriorly. So we expect the nerve between C6 and C7 to be damaged right here. So we just need to know what nerve this is. Recall that in the cervical spine, the spinal nerve exits above its corresponding vertebra. So the spinal nerve exiting above C7 would be the C7 spinal nerve. Remember that from T1 and below, this pattern no longer exists. Instead, each spinal nerve exits below its corresponding vertebra. So starting here and down, we will get T1 under the T1 vertebrae, and the T2 spinal nerve, and the T3 spinal nerve, and the T4 spinal nerve beneath the T4 vertebra. Now let's talk about the caudalmost portion of the spinal cord. This is figure 8.12 from your text, and this is anterior, and this is posterior. We can see from this image that the spinal cord actually ends around this portion, right here, between the L1 and L2 vertebrae. However, the spinal nerves continue down and exit at their appropriate levels between the vertebrae. In other words, although the spinal cord ends up here, between the L1 and L2 vertebrae, the spinal nerves will still continue down and exit at their appropriate level. For example, the L5 spinal nerve will exit beneath the L5 vertebra. Another fact you need to know is how far down the dural sac descends. Knowing where the dural sac ends is very clinically relevant because when a lumbar puncture is performed, the physician is trying to extract CSF, which means they want to be within the subarachnoid space. However, they want to insert the needle below the spinal cord so as not to cause spinal injury. In other words, lumbar punctures are traditionally performed at the L4, L5 vertebral level or the L3, L4 vertebral level. There's another similar procedure called an epidural anesthesia. For an epidural anesthesia, the needle is inserted above the dura mater, so within this epidural space. In this type of anesthesia, the needle does not puncture the dural sac and does not enter the CSF. So it would just enter in like a lumbar puncture, but then it would just go up instead of puncturing the dural sac. The different clinical scenarios in which you would perform an epidural anesthesia versus a lumbar puncture is not nearly as important as knowing the anatomy of this level of the spinal cord, as shown in figure 8.12. Another thing to know is that clinically, the physician will use landmarks on the outside of the body to guide the lumbar puncture. One of the most important landmarks is the iliac crest, which lines up very well with the L4 vertebral body. You can see that if the clinician can find the iliac crest, they can find the appropriate lumbar level in order to perform lumbar puncture or an epidural anesthesia. It's important to memorize the layers of this image, so let's do a practice question without the labels. So let's say a patient is about to receive a lumbar puncture. After puncturing the ligamentum flavum, what layers must the needle penetrate before entering the CSF? So, as you recall, the clinician will find the iliac crest, I'll just write IC, which lines up with the L4 vertebral body, and then he will puncture between the L3 and L4 vertebral level, let's say. And after puncturing the ligamentum flavum, which is this blue part, you will enter the epidural space and then puncture the dura mater and the arachnoid mater before finally entering the subarachnoid space to enter the CSF. Let's just review the basic things about the spinal cord that you need to know. So the spinal cord contains white matter, which is on the outside, and gray matter, which is on the inside. And the white matter sends information from the brain to the periphery and from the periphery to the brain. The gray matter is actually where these cell bodies are, and these are unmyelinated, which is why they are gray. Each spinal nerve exits above its corresponding vertebrae down through C7, including C7. However, spinal nerves C8 and lower exit below their respective vertebrae. And also remember that lumbar punctures are performed at the L3, L4 vertebral level or the L4. We will discuss each spinal tract. So let's get started. So the spinal tracts include the dorsal column, the spinothalamic tract, and the corticospinal tract. And oftentimes the dorsal column is referred to as the DCML, or the dorsal column medial lemniscus pathway. So let's first start with the dorsal column. The dorsal column carries vibration and proprioception to the brain. It travels up the posterior or dorsal part of the spinal cord, hence the name dorsal column. And it'll travel through either the fasciculus gracilis, which is for the lower extremities, or the fasciculus cuneatus for the upper extremities. Now the first synapse occurs in the ipsilateral medulla on the nucleus cuneatus or gracilis, depending on whether or not it traveled using the fasciculus cuneatus or the fasciculus gracilis. And we'll show that in a moment. And the neuron, once it reaches the medulla, will then decussate, so it'll cross to the contralateral side and then travel through the medial lemniscus pathway, which is where we get the ML in DCML. And then it just continues upward. Then there's a second synapse between the second and third neurons in this pathway, and that occurs in the VPL, or ventral posterior lateral nucleus of the thalamus. Then the tract continues to the primary somatosensory cortex. So let's draw this out. So this is figure 8.13 from your text, which outlines the pathway for the dorsal column. As we mentioned before, sensation comes in through the dorsal root and into the spinal cord. The dorsal column is specifically responsible for vibration and proprioception, as labeled here. Proprioception tells your brain where your body parts are at all times. And once in the spinal cord, the tract will continue up the dorsal column. So as you can see on this image, the dorsal column is divided based on different parts of the body. So it can be the fasciculus gracilis or the fasciculus cuneatus. The gracilis being the inner portion and the cuneatus being the outer portion. If sensation is coming from the lower extremity, it'll travel up the dorsal column through the fasciculus gracilis, and if it's coming from the upper extremity, it'll travel through the dorsal column using the fasciculus cuneatus. So now I'm just going to erase this so we can focus on just the tract. So the tract then continues up along the ipsilateral side until it reaches the medulla. Notice how there's not been any synapsing up to this point. It has just been one single axon from way down here, where the sensation came from, to all the way up here, to our first synapse. And then we have the synapse in the medulla, the ipsilateral side. There's a nucleus gracilis or nucleus cuneatus, and what nucleus the nerve will synapse to depends entirely upon which pathway it used, the fasciculus gracilis or cuneatus. From here, this second neuron decussates within the medulla and travels up using the medial lemniscus. And the only thing you need to know about the medial lemniscus is that it's the latter portion of the DCML, and it's just this pathway. So think of it as the pathway from the medulla to the thalamus, so essentially the second neuron. So we're using the medial lemniscus, and this neuron goes until it reaches the thalamus, and again it synapses onto the ventral posterior lateral nucleus of the thalamus. So then this third neuron now travels up until it reaches the primary sensory cortex. And this is discussed in section 1 of this chapter. So to summarize figure 8.13 from your text, sensation travels through an axon that enters the dorsal root, travels up the dorsal column and synapses onto a nucleus within the medulla, then crosses to the medial lemniscus. It then goes up to the VPL in the thalamus, where the second synapse occurs. Then the third neuron carries information to the somatosensory cortex. So if a patient has a damaged dorsal column, like right here, then they are not going to be able to sense vibration and proprioception below that level on the ipsilateral side, so staying on this side. But if damage occurs up here following the decussation, then of course the patient would have contralateral loss of vibration and proprioception. So some pearls to keep in the back of your mind is that two major causes of dorsal column damage, so the DC part, of the DCML is B12 deficiency and tertiary syphilis. So dorsal column damage is anything prior to the decussation before the medial lemniscus pathway. So anything in this side. So this would be considered the dorsal column aspect. So you would get ipsilateral signs with damage to the dorsal column. So now let's dive a little deeper with a question. So a male patient has damaged the left dorsal column at the L1 spinal cord level. What will be his symptoms and where will he experience them? Okay, so this is the patient's left and this is the patient's right. And so he's damaged the dorsal column on the left side. So this side over here. And we know that the dorsal column carries vibration and proprioception. So we know that if this patient has damaged the left part of the dorsal column, he will lack vibration and proprioception. The only question that remains is where will he experience them? So let's quickly review the pathway of the dorsal column by looking at a diagram of a man as well. So again, the man has damaged the left part of the dorsal column at the L1 spinal cord level. And recall, by looking at the L1 spinal cord level on the man, the sensation comes in through the dorsal root ganglion, travels up the dorsal column, all the way up until the tracker reaches the medulla, and then it synapses, and then there's a decussation that travels up to the VPL of the thalamus, and then to the somatosensory cortex. So we'll just write cortex. So in this man, this portion is damaged. This means that any signals that try to use the dorsal column below the L1 spinal cord level is stopped. So as you can see, if sensation is trying to come up through his big toe, it'll stop once it reaches this L1 spinal cord level. Even if it goes to S2 and then travels up, it'll stop. So vibration and proprioception below the L1 spinal cord level will be damaged on the ipsilateral side. So let's do another question. What symptoms would a patient experience if only the lateral portion of the right dorsal column was damaged at the C4 spinal cord level? So in this question, we need to make sure we recognize that the dorsal column carries the fasciculus cuneatus and the fasciculus gracilis. So we know that this side is the patient's right, and this side is the patient's left, and this is the C4 spinal cord level. And that makes sense because this image looks like a cervical spinal cord level based on its unique shape, which we discussed in part 1 of this section. So if the right lateral portion of the dorsal column is damaged, we'll fill in this damaged area here. As we discussed on the previous slide, anything below this lesion on the ipsilateral side will experience loss of vibration and proprioception. However, if the medial portion was spared, as in this case, that means that some tracts are fully functional. So as I've written here, with a G, the fasciculus gracilis is spared on both sides of this patient. So this patient has damaged the fasciculus cuneatus, as we just mentioned, but it's helpful to look at the image of the man as well, because we can easily remember that the fasciculus cuneatus on either side is responsible for carrying information to the upper limbs, because they are on the outside. However, the fasciculus gracilis is on the inner portion, the medial portion of the dorsal column, which is responsible for carrying information to the legs on the inside. So the arms are far out laterally, and so the lateral portion of the dorsal column, the fasciculus cuneatus, is in the lateral portion as well. So feet in, arms out. So going back to the question, a patient who has damaged the lateral portion of the right dorsal column, so right here, at the C4 spinal cord level, would lose vibration and proprioception of the arm, but not the leg. So we will write the right upper extremity experiences loss of vibration and proprioception, but the right lower extremity is spared. So now we need to talk about the Romberg test really quick. Now this is very important as it relates to the dorsal column. It's really high yield for examination purposes. So it's used to determine the cause of ataxia. It really helps to distinguish between dorsal column damage and cerebellar ataxia. Now, just recall that ataxia means gait abnormality. So a patient's walking funny, and you want to know if it's the cerebellum that's the problem or if the dorsal column is the problem. So to understand the Romberg test, it's important to recognize that a patient requires 2 of the 3 following things in order to stand and have normal gait. They need proprioception. In other words, they need the dorsal column, medial lemniscus pathway fully intact. They need vision. They need to be able to see where they are. And they need vestibular function, which helps them balance. And if they lose one of those, let's say proprioception, then when they're walking around, they have vision and vestibular function, which means that they can walk totally normal because they have 2 of the 3. However, if you ask them to close their eyes, which is what the Romberg test is, if you ask them to close their eyes while standing still, then they have essentially lost their vision, which means they only have 1 of the 3. And this means that this patient will lose balance. And if this happens, then you know, okay, they have obviously damaged the dorsal column because they have a positive Romberg's test. Now let's talk about the spinothalamic tract. The spinothalamic tract carries pain and temperature sensation from the periphery to the brain. The first synapse occurs in the ipsilateral gray matter of the posterior horn. So this synapse occurs in the actual spinal cord, not the medulla in the brainstem like the dorsal column did. So this first synapse occurs much earlier in the pathway. The neuron then decussates through the anterior white commissure until it reaches the lateral white matter on the contralateral side, and then it continues upward from there. And then it goes straight through the medulla until finally it reaches the thalamus, and the second synapse occurs on the VPL, just like in the dorsal column. And then the tract continues to the primary somatosensory cortex, just like in the dorsal column. So let's draw this out. So this is figure 8.14 from your text. Pain and temperature sensation enter through the dorsal root. Again, the cell body for this first neuron lies within the dorsal root, hence the name dorsal root ganglion. And the first neuron then enters the posterior horn of the gray matter. And again, the gray matter is this dark blue, and the synapse occurs right here in the posterior horn. Then the second neuron then crosses to the contralateral side using this anterior white commissure. So the nerve then finally reaches the contralateral side at the anterior lateral white matter, hence the term anterolateral system, which is a synonym for the spinothalamic tract. And then the tract just travels straight up, no more decussation. It goes straight up to the thalamus, synapses onto the VPL, and then finally enters the primary somatosensory cortex. So something that's really important for distinguishing the spinothalamic tract from the dorsal column pathway is that the decussation happens early in the spinal cord. Like as soon as the pain and temperature come in, there's a decussation. Whereas in the dorsal column, the decussation happens up here in the medulla. So now let's do a question. So a patient is involved in a serious car accident and has lost pain and temperature sensation of the right lower extremity. Where is the lesion likely to be on the spinal cord? Okay, so the patient has lost pain and temperature sensation of the right lower extremity. So their right leg. The spinal cord region responsible for the leg is primarily lumbar, so I will just write a capital L here in the lumbar region. We discuss dermatomes in greater detail later in this chapter. For now, just recognize that this patient has lost pain and temperature for the entire leg, and we suspect that the lumbar region is responsible for that. So now we want to know exactly where on the spinal cord the patient has damage. The spinothalamic tract comes in, this right side, there's a synapse immediately, and the second neuron then crosses the anterior white commissure, travels all the way up until it reaches the VPL, and then finally to the somatosensory cortex. I will just write cortex. So let's say as a clinician you get more information and you receive the results of the x-ray and you find that the L2 spinal cord is specifically damaged. Now if you damage the posterior horn of the gray matter right here, then you would definitely interrupt the spinothalamic tract at the L2 level because the nerve would come up and the first neuron would synapse here in the posterior gray horn, and then the second neuron would then travel over and then travel up. So pain and temperature sensation would definitely be lost at the L2 spinal cord level. However, anything above L2, for example L1, would be just fine because it can come in, synapse onto the gray matter, and decussate and travel up, and anything below, like L3, can do the same thing. To illustrate this, let's add in every level from L1 to S1, and as you can see, they're labeled here. So as you can see, if damage to the posterior horn of L2, right here in the gray matter, if that was damaged, that would leave signals from L1 up and L3 down unaffected. As we can see, the nerve will come in, synapse, and come up just fine. This is the same for every single level from L3 down to S1. Whereas the L2 spinal cord level would just be damaged, and you'd lose signal at that specific level. And if this were the case, then this patient would only have loss of pain and temperature sensation at the L2 dermatome, which would look something like that. This patient, however, has the entire leg with loss of pain and temperature. So it would not make sense that damage to the posterior horn of the gray matter is the culprit of his findings. So we'll erase this. We no longer suspect the posterior horn of the gray matter. So what else could have caused a loss of pain and temperature sensation in the entire lower right extremity? So another possibility is that the anterolateral portion of the white matter is damaged at the L2 spinal cord level. So in other words, right here in this region. That means the nerve would come in, synapse here in the posterior horn of the gray matter, decussate, and try to travel up, but it can't. It stopped because of the damage in the white matter. So this would mean that every level of the spinal cord from L2 and down would actually be unable to get their signals up. So if the anterior white matter was damaged, then these nerves would not be able to carry their signal out to the brain. So the patient would lose all sensation from L2 and down, which would explain why this patient has lost all of the right lower extremity, pain and temperature. So going back to our question, with total loss of pain and temperature from the right lower extremity, we expect that there was damage to the anterior lateral white matter. Now let's do another question. Let's say a patient has damaged the anterior white commissure of the T1 spinal cord. What symptoms would you expect? So recall that the anterior white commissure is right there, and it's used by the spinothalamic tract. Recall that as the signal enters, synapses in the posterior horn, and then decussates in this white matter here, and then travels up. Same thing with the other side. Synapses here in the posterior horn, uses the anterior white commissure, and then travels up. So if the patient has damaged the anterior white commissure of the T1 spinal cord right here, then the patient would lose pain and temp sensation coming in from either side. But this would be at just the T1 spinal cord level, because as you recall, if this part is spared, then everything coming above T1 and anything coming from below T1 would be able to carry its signal just fine up to the brain, because the pathway is totally fine. as we described in a previous section. So the patient would only lose pain and temperature at the T1 spinal cord level. A disease that classically causes these findings is called syringomyelia, and this occurs when a syrinx, a fluid-filled cavity, develops in this portion of the spinal cord that we've just talked about, often in the C8 to T1 distribution. So this patient demonstrates that classic syringomyelia of loss of pain and temperature just in the T1 dermatome. So now let's talk about the corticospinal tract. Now the corticospinal tract carries motor input from the brain to the body. Now the first neuron originates in the primary motor cortex. Then it travels through the internal capsule and the medulla. At the level of the medulla, the corticospinal tract then decussates, specifically at the medullary pyramids, and then the contralateral tract then continues down within the posterolateral white matter until the axon actually reaches the appropriate level. And then at that point, it enters the anterior horn of the gray matter within the spinal cord. And this is where the first synapse occurs. It actually occurs here in the anterior horn, and then the second neuron exits the spinal cord through the anterior root. Unlike the ascending tracts, such as the dorsal column and the spinothalamic tract, which came in through the dorsal root, the corticospinal tract exits through the anterior root. And then the second neuron then synapses at the neuromuscular junction. So let's draw this out. So this is figure 8.15 from your text, and up here is the cerebral cortex, specifically the primary motor cortex of the frontal lobe. The neuron originates here and then descends through the internal capsule, then reaches the medulla, and then decussates at the medullary pyramids, as labeled here, the medullary pyramidal decussation. The tract then continues within the white matter until it reaches the appropriate level. So as you can see, this is a cervical spinal cord, and for this particular neuron, it'll come down, stay within the white matter until it reaches the level that it needs to send its neuron out, and at that point, it'll cross over into this anterior horn of the gray matter. And then finally, the second neuron then leaves through the anterior root and then goes to the neuromuscular junction, where it performs its action. So notice how the signal originated in the cortex at this portion of the brain, indicating it would be the upper limb. However, if the signal originated from this portion right here of the cortex and then traveled down, we would think that this would be the lower limb. And this is where it's really important to be familiar with the homunculus, which is figure 8.6. So for more information on the homunculus, please visit section 1 of this chapter. So now let's talk about upper and lower motor neurons. The upper motor neuron and the lower motor neuron refer to the two neurons that make up the corticospinal tract that we just discussed. So this first one in red would be the upper motor neuron. This lower one in blue would be the lower motor neuron. Now, upper motor neuron lesions damage that first neuron, as mentioned. So signs of upper motor neuron damage would be the Babinski reflex. And this is where the bottom of the foot is stroked and the patient's big toe ends up pointing up, as in upper motor neuron. Now, the Babinski reflex is normal in infants, but it's not normal in adults. The patient's feet should squeeze down and toes point down. So if you get the Babinski reflex in an adult, you're thinking about upper motor neuron damage. Another symptom is spastic paralysis and clasp knife spasticity. Another important gem is to remember that upper motor neuron damage increases. It increases tone and reflexes, whereas lower motor neuron damage decreases. It decreases tone and reflexes. Another sign of lower motor neuron damage is atrophy and fasciculations. Fasciculations are just muscle spasms. They're pretty strong in these patients. They're not like typical muscle spasms, but that's a safe way to think about them. So now let's look at figure 8.15 from your text. This first neuron is the upper motor neuron, and the second neuron is the lower motor neuron. And if we damage this first neuron, we would get the Babinski reflex and increased tone and reflexes. The patient could also demonstrate clasp knife spasticity and spastic paralysis. Now, if we damage the lower motor neuron, we would get signs of lower motor neuron damage. So we would get decreased tone and reflexes, fasciculations, and atrophy. In either situation, whether damaging the upper motor neuron or the lower motor neuron, the patient would demonstrate weakness because the signal from the brain to the neuromuscular junction is damaged. So the patient would just be weak at that level. So now let's do a question. A patient has hydrocephalus. What would you expect to have happen to the deep tendon reflexes? Now, hydrocephalus doesn't always cause alterations of deep tendon reflexes, but when it does, what do you expect? Well, a hydrocephalus would definitely affect the upper motor neuron, not the lower motor neuron. So recall the symptoms for upper motor neuron lesions are increased tone and reflexes, the toes point up, so positive Babinski, and spastic paralysis. And of course, clasp knife spasticity as well. But the point is that if we damage the upper motor neuron with a hydrocephalus, then there would be increased tone and reflexes, so the deep tendon reflexes would be increased. Let's do another question. Let's say an elderly male patient complains of being unable to move his right upper extremity. Upon examination, his right upper extremity is very stiff. Where could this lesion be? So what's being described in this scenario is spastic paralysis. So notice that his arm is paralyzed, he's unable to move his right upper extremity, and he's demonstrating stiffness or hypertonia. So we believe that he has spastic paralysis, which is a sign of an upper motor neuron lesion. Whenever you get an upper motor neuron or lower motor neuron question, think of the corticospinal tract. So let's take a look at that really quick. The patient demonstrates signs of an upper motor neuron lesion in the right upper extremity. So we know that the upper motor neuron that is affected originates in the left motor cortex. And we'll make sure we understand that it's in the appropriate part of the homunculus. Recall that the pathway, then the neuron travels down the internal capsule, and then it decussates at the medullary pyramids and descends in the white matter until it reaches the appropriate level, and then it enters the gray matter, the anterior horn, synapses, and then leaves through the anterior root to the neuromuscular junction. Damage could be anywhere along this pathway. So specifically, we're talking about the right upper extremity, which makes sense because this is a cervical spinal cord level. But this patient has spastic paralysis. So we know that it's an upper motor neuron. So this patient could have damage anywhere from here to here. So with the information given in the question, you cannot actually identify the exact location of the damage for the upper motor neuron. It could have happened prior to the decussation or after the decussation. However, if I now told you that the patient had an MCA stroke, then where would you identify the lesion? So you would then focus your attention on the brain where strokes occur. And you would think that the lesion happened prior to the decussation. So you'd focus your attention simply on the MCA area or the motor cortex. So another question. Let's say a 5-year-old unvaccinated infant who recently moved to the country has muscle fasciculations. And he has them in all 4 limbs. Where's the problem? We'll first identify the symptom as a lower motor neuron lesion. And recall that signs of lower motor neuron lesions include decreased tone and reflexes, fasciculations, and atrophy. So we believe that this patient has a lower motor neuron lesion. So since we have identified the lesion as being a lower motor neuron problem, we can focus our attention on just the spinal cord and ignore the brain. Recall that the lower motor neuron begins with the cell body in the anterior horn of the gray matter. So somewhere from here to the neuromuscular junction is damaged. But recognize that this is in all 4 limbs, so it's not just the spinal cord level. Since this patient is unvaccinated and from out of the country, poliomyelitis is a possibility. Poliomyelitis actually causes damage to the anterior horn cells. So poliomyelitis would explain the lower motor neuron signs in all 4 extremities, because we'd expect this to happen in more than just the cervical spinal cord. We'd expect it to happen in the cervical, thoracic, lumbar, and sacral levels. Poliomyelitis can affect all of these, which explains why the patient has damage to all 4 limbs and has these muscle fasciculations. However, in real-life situations, poliomyelitis is typically asymmetric. So whenever you see symptoms of lower motor neuron lesions, you should think of the anterior horn and below, as shown here. Now let's do a question to tie it all together. So let's say a patient has left-sided Brown-Séquard syndrome. This is at the T9 spinal cord level. What will be the symptoms? Okay, so here we have a cross-section of the T9 spinal cord, and this portion would be totally damaged. And that's what Brown-Séquard syndrome is. So it's a complete hemisection of one side of the spinal cord. And so this is the patient's left, hence left-sided Brown-Séquard syndrome. So let's think of all 3 tracks one by one. So first let's think of the dorsal column, which comes in, enters through the dorsal root ganglion, and then it doesn't synapse, but just stays ipsilateral and goes up. So if the dorsal column is damaged, this portion right here, then everything below the T9 level would experience loss of vibration and proprioception. So if we draw T9 right here, then we would expect the patient would have lost vibration and proprioception everywhere on the ipsilateral side below the T9 spinal cord level. So right, loss of vibration and proprioception. Now let's talk about the spinothalamic tract. Now this comes in, goes through the dorsal root ganglion, and it synapses in the posterior horn, and then decussates through the anterior white commissure, and then travels up to the thalamus. So everything above and below T9 on the left side will be able to travel up as normal. And we demonstrated this earlier in the lecture, but just to reiterate, it could come in through a lower spinal cord level, decussate, and then travel up as normal, and the same thing for above the T9 level. So we will erase this for now, and we will demonstrate the loss of sensation on this man on the right. So everything above and below T9 on the left side will be able to travel up as normal. So there will be no deficit on this left side. So no pain and temperature loss on the left. Except at the T9 level, where we can clearly see the posterior horn is damaged from the Brown-Séquard syndrome. However, on the contralateral side, which uses this portion of the white matter, we'll lose the pain and temperature sensation. So we can demonstrate that the spinothalamic tract comes in, this first neuron, it synapses on the posterior horn, and then it decussates at this anterior white commissure, and then it tries to use this anterior lateral portion of the white matter. But this portion is damaged. That means that anything below T9 on the contralateral side will be unable to travel up. So I'm just demonstrating some lower spinal cord levels, and you can see they just get stopped because of the damage from this Brown-Séquard syndrome. So I'll demonstrate this on this man. So everything on this contralateral side will have lost pain and temperature. Now let's move on to the corticospinal tract. If the anterior horn of the gray matter is damaged, so this region here, then the patient would demonstrate lower motor neuron lesion signs on the ipsilateral side at the T9 level. So everything through here would demonstrate lower motor neuron signs, because every axon traveling down on this ipsilateral side would not be able to synapse appropriately with the anterior horn. And actually, since this portion of the spinal cord is damaged as well, that means you're going to get upper motor neuron signs below this level. So this patient would actually demonstrate upper motor neuron signs below the T9 level as well. And that concludes the section.
Welcome to Section 3 of Neurology. This section is divided into 2 parts. In the first part of this section, we'll be introducing cranial nerves and going through several examples. In the second part, we'll focus on examples and we will integrate the remaining material. So let's get started. The first topic is the corticobulbar tract. This is figure 8.5 from your text, which shows a coronal view of the brain. For step 1, you need to know that the corticobulbar tract is a cranial nerve pathway that connects the upper motor neurons to the lower motor neurons. Remember, all motor information originates from upper motor neurons in the primary motor cortex. This remains true when we talk about the cranial nerves. So an upper motor neuron originates in the primary motor cortex, which we'll assume is about right here, this region where I'm drawing circles. And these neurons send axons down through the brain and through the internal capsule. So down through the internal capsule. Recall from section 1 that the corticobulbar tract passes through the genu of the internal capsule. Once past the internal capsule, the axons decussate just above each lower motor neuron in the brainstem. Let's imagine that this represents the brainstem. We'll say this is the midbrain, the pons, and the medulla. So again, the lower motor neurons of the cranial nerves are located within the brainstem, which I'll draw here. These are also called cranial nerve nuclei. It's important to know that many of the cranial nerve nuclei span large segments of the brainstem. So for example, while the trigeminal cranial nerve may emanate from the pons, the nucleus of the trigeminal cranial nerve may actually be seen in the pons, medulla, and even part of the cervical spinal cord. Okay, once the axons from the upper motor neurons pass the internal capsule, they decussate directly superior to the cranial nerve nucleus that they innervate. So for example, the third and fourth cranial nerve nuclei are in the midbrain. So we'll write third and fourth. So the axons innervating these nuclei would cross over right above that region. So again, this is the left side of the brain, and this is the right side of the brainstem. So this blue circle would represent the third and fourth cranial nerve nuclei on the right side of the brainstem. Obviously, the opposite side of the brain would do the same thing. It would cross over directly above the lower motor neuron that is innervated. This same principle holds true for all the cranial nerve nuclei receiving motor information from the primary motor cortex. Finally, it's important to recognize that the corticobulbar tract is quite complicated, and lesions of the tract are fairly unpredictable. So please don't spend time memorizing all of the intricacies of the corticobulbar tract. If you understand the general idea and the pathway we just covered, you'll be well prepared for step 1. Okay, with this in mind, let's look at cross-sections of the different levels of the brainstem to look at each of the cranial nerve nuclei. This is figure 8.16, which shows a transverse section of the midbrain. This is anterior and this is posterior. For step 1, you need to be able to recognize a transverse section of each level of the brainstem. The midbrain can be easily identified by the cerebral crura, which are right here. I use this to remind me that the midbrain looks like 2 legs. So kind of like this. You could also use the substantia nigra, which is this dark pigmented region right here, or the red nucleus, which is this region right here. These will both help remind you that you're looking at a section of the midbrain. Okay, with this in mind, let's look at the cranial nerve nuclei in the midbrain. Again, as I mentioned on the previous slide, many of the cranial nerve nuclei span large segments of the brainstem. However, as a general rule of thumb, the nucleus of the cranial nerve can be found wherever the peripheral branch emanates from the brainstem. So, for example, the peripheral branches of cranial nerves 3 and 4 emanate from the midbrain. So we can deduce that the nuclei for these cranial nerves must also be in the midbrain. The peripheral branches of cranial nerves 5 through 8 emanate from the pons. So we can deduce that the nuclei for these cranial nerves must also be in the pons. The peripheral branches of cranial nerves 9 through 12 emanate from the medulla. So we can deduce that the nuclei for these cranial nerves must also be in the medulla. One exception to this rule is the nucleus of cranial nerve 11. The nucleus of cranial nerve 11 resides in the cervical spinal cord, but the peripheral branch of this nerve emanates from the medulla. Finally, remember that cranial nerves 1 and 2 do not emanate from the brainstem. So in this case, we're looking at a section of the midbrain, so we should expect the nuclei of cranial nerves 3 and 4 to be present here. I find it helpful to keep in mind that most of the cranial nerve nuclei are directly adjacent to the cerebral aqueduct or fourth ventricle. We'll talk about this in more detail later, but recall that the cerebral spinal fluid moves from the third ventricle into the fourth ventricle via the cerebral aqueduct. In this image, we can see the cerebral aqueduct right here. With this logic, we'd expect the nuclei for cranial nerves 3 and 4 to be close to the cerebral aqueduct, which they are. From this figure, we can see the nucleus of the oculomotor nerve, or cranial nerve 3, right here. We can't see the nucleus for the trochlear nerve, or cranial nerve 4, because it's directly inferior to the oculomotor nucleus. However, if we took a cross-section of the midbrain directly below this region, we'd have a very similar figure, and we'd be able to see the trochlear nucleus. For your reference, this is a myelin stain of an actual microscopic cross-section of the midbrain. For step 1, it's important for you to be familiar with these myelin stains of the brainstem. You need to be able to recognize what segment of the brainstem you're looking at and have a general idea of the location of the major landmarks. Okay, now let's look at a cross-section of the pons. This is figure 8.18, which shows a transverse section of the pons. Again, this is anterior and this is posterior. The pons can be easily identified by the transverse pontine fibers, these little fibers right here. If you can't find the transverse pontine fibers, then you should still be able to deduce that you're looking at the pons by process of elimination. This is because the midbrain and the medulla have a very distinct appearance. Okay, with this in mind, let's look at the cranial nerve nuclei in the pons. Recall that cranial nerves 5 through 8 emanate from the pons. Remember, most of the cranial nerve nuclei are directly adjacent to the cerebral aqueduct or fourth ventricle, I'm not going to go through each of the cranial nerve nuclei, but I'd like to briefly mention the importance of the solitary nucleus. For step 1, you need to know that the solitary nucleus is a large nucleus that spans much of the brainstem and contains sensory information for cranial nerves 7, 9, and 10. I use the letter S in the word solitary to help remind me that this nucleus contains sensory information. Rather than memorizing all of the details of cross-sections of the brain, I find it helpful to use a landmark called the sulcus limitans as a guide to answering many of the cross-sectional questions you'll see. The sulcus limitans, which is approximately right here, is useful because it divides the sensory nuclei from the motor nuclei. Those nuclei lateral to the sulcus limitans are sensory, and those nuclei medial to the sulcus limitans are motor. I use the letter M in the word medial to help me remember that the nuclei medial to the sulcus limitans are motor nuclei. So in summary, if you can identify what section of the brainstem you're looking at, and you know that the nuclei located laterally are associated with sensory information, then you should be able to get all the step 1 questions correct that are associated with this topic. For your reference, this is a myelin stain of an actual microscopic cross-section of the pons. You can clearly see the transverse pontine fibers right here. This is figure 8.20, which shows a transverse section of the medulla. This is anterior, and this is posterior. The medulla can be easily identified by the inferior olivary nucleus. Recall that cranial nerves 9 through 12 emanate from the medulla. So 9 through 12. Remember, most of the cranial nerve nuclei are directly adjacent to the cerebral aqueduct or the fourth ventricle, which you can see right here in this image. Again, I'm not going to cover all the nuclei in this image, but notice the solitary nucleus, the dorsal motor nucleus, and the nucleus ambiguus. Remember that the sulcus limitans is about right here, which means any nuclei lateral to this point are sensory nuclei. Using this trick, we can easily deduce that the solitary nucleus must be involved in processing sensory information, as we just discussed, and also that the nucleus ambiguus and dorsal motor nucleus must be involved in processing motor information. So motor. And the sulcus limitans is about right here. For step 1, you need to know that the nucleus ambiguus is a large nucleus that spans much of the brainstem, and the dorsal motor nucleus is found in the medulla. The nucleus ambiguus contains somatic motor information, and this is for cranial nerves 9 and 10. You also need to know that the dorsal motor nucleus contains parasympathetic motor information. And this is specific for cranial nerve 10, and it sends parasympathetic motor information to the heart, lungs, and upper GI tract. For your reference, this is a myelin stain of an actual microscopic cross-section of the medulla. We can clearly see the inferior olivary nucleus right there. This is figure 8.22, which shows an anterior view of the peripheral branches of the cranial nerves emanating from the brainstem near the location of their respective nuclei. I'm not going to point to and name each cranial nerve, but it's important that you spend time memorizing this image. If you were to see an unlabeled picture similar to this, you'd be expected to know where each cranial nerve is. In addition to knowing where each cranial nerve emanates from, you also need to know through which foramina in the skull they exit. This is figure 8.23, which shows a superior view of the foramina of the skull. Again, I'm not going to point to and name each foramina, but it's important that you spend time memorizing this image. You need to know the name of each foramen and which nerve or nerves exits through the opening. This is figure 8.24, which shows a coronal view of the cavernous sinus. For step 1, you need to know which cranial nerves pass through the cavernous sinus. As we can see from this image, cranial nerves 3, 4, part of 5, so V1 and V2, as well as cranial nerve 6, all traverse the cavernous sinus. We can also see the optic chiasm right here, which is part of cranial nerve 2, and that is directly above the cavernous sinus. If you were to see an unlabeled picture similar to this, you'd be expected to know where each cranial nerve is, so take some time to memorize this image. This is table 8.1 from your text, which provides an overview of the cranial nerves and their functions. This table is incredibly high yield. I cannot emphasize this enough. You'll be tested on these nerves and their functions over and over and over again. If a table format doesn't work for you, there are many mnemonics, songs, pictures, and other resources on the internet to help you memorize the cranial nerves and their functions. Regardless of how you memorize this information, you'll definitely be tested on it for step 1, so take some time to commit this to memory. Okay, before we move on to the practice questions and begin tying all this information together, I'd like to take a second and review some details about cranial nerves 5 and 7. Cranial nerve 5 has a somewhat unique tract, so we'll briefly cover that now. So here is a face. We have the eyes, the nose, and the mouth. Recall that the ophthalmic branch, so V1, is responsible for sensation around the eyes and the forehead, like this. The maxillary branch, so V2, is responsible for sensation around the maxilla, like this. And the mandibular branch, so V3, is responsible for sensation around the mandibles, like this. It's also responsible for sensation around the anterior 2/3 of the tongue and the muscles of mastication. Each of these peripheral branches brings sensory information into the brainstem. It's important to know that information about proprioception and vibration travel to the principal nucleus, which is in the pons. So we'll say the principal nucleus is right here in the pons. Again, this is responsible for information about proprioception and vibration. This information decussates or crosses over to the opposite side of the body immediately. So all of these nerves have been drawn on the right side of the patient's face, and any information about proprioception and vibration goes into the right principal nucleus, like this. After it enters the principal nucleus, it can decussate immediately to the left side of the brainstem. So left side of the brainstem. On the other hand, pain and temperature information travels to the spinal trigeminal nucleus, which is in the medulla and the cervical spinal cord. So medulla and cervical spinal cord, we have the spinal trigeminal nucleus. This nucleus is responsible for information about pain and temperature. Because this nucleus is so large and descends into the cervical spinal cord, information about pain and temperature must travel all the way down into the spinal cord before decussating. So again, any information about pain and temperature coming from the right side of the face must travel down to the right spinal trigeminal nucleus. I'll draw that here. At this point, the information can decussate and ascend back up through the brainstem. At this point, both tracks converge and then travel up together to the ventral posteromedial nucleus of the thalamus. So both tracks ascend to the ventral posteromedial nucleus of the thalamus. This is the most important part of the pathway to be familiar with. Remember, all sensory information coming from the trigeminal nucleus and the principal nucleus synapses on the ventral posteromedial nucleus of the thalamus. Knowing that all sensory information from the trigeminal nerves synapses on the VPM is the most important part of this pathway. Finally, all the sensory information then travels to the primary sensory cortex, PSC. Okay, now let's talk about the facial nerve. The nucleus for cranial nerve 7 in the pons is unique because, unlike the other cranial nerves, it receives dual innervation from the cortex. Let's draw this out so you can see what I'm talking about. This will represent the facial nucleus, which contains an upper component, we'll do a U for short, and a lower component, L for short. The upper component receives innervation from both cerebral cortices. So this will represent the primary motor cortices, and again, the upper component receives dual innervation, so innervation from both the left and right primary motor cortex. On the other hand, the lower component only receives innervation from the contralateral cortex, so like this. It's important to know that the upper component of the facial nucleus innervates the superior aspect of the face. So very simply, this will be our face, and the upper component innervates the superior aspect of the face, whereas the lower component innervates the inferior aspect of the face. We'll go through some examples later on in this lecture, but as you can see from this diagram, a lesion to the cortex would cause paralysis of the inferior aspect of the face. So imagine if we lesioned the cortex, both of these pathways would be knocked out, but because of the dual innervation of the opposite side, the upper component of the facial nucleus would still be intact, meaning the upper face would be spared and the lower face would be paralyzed. So again, a lesion to the cortex would cause paralysis of the inferior aspect of the face, sparing the superior aspect of the face. On the other hand, a lesion to the facial nucleus in the pons would cause complete paralysis of the face. This is because both the upper and lower components would be destroyed. This is figure 8.25 for your review, which illustrates the facial nerve pathway that we just discussed. Okay, let's jump into the questions. A patient has an inability to taste on the posterior 1/3 of the right part of her tongue. Which part of the brainstem shown below is likely damaged? In order to get this question right, you first need to be able to recognize the different regions of the brainstem. Recall that the inferior olivary nucleus is right here, and it's only found in the medulla, which means we're looking at a transverse section of the medulla. You also need to remember from table 8.1 that cranial nerve 9, or the glossopharyngeal nerve, is responsible for taste and general sensation of the posterior 1/3, so posterior 1/3 of the tongue. Because this patient's right tongue is affected, we can deduce that the right side of the brainstem must be affected. So again, this would be right, and this would be left. Because we're looking at the medulla, we should know that this region here is the fourth ventricle. So fourth ventricle. And recall that all of the cranial nerve nuclei are close to the fourth ventricle or the cerebral aqueduct, depending on the region of the brainstem we're looking at. Finally, as I mentioned earlier, identifying the approximate region of the sulcus limitans can help us separate the sensory nuclei from the motor nuclei. In this case, the sulcus limitans is about here. This means that nuclei lateral to the sulcus limitans are associated with sensory information. This means the damaged nucleus must be somewhere in this region here. This is lateral to the sulcus limitans, and it's on the right part of the medulla. More important than knowing the exact location of the sulcus limitans is recognizing that the lateral aspect of the brainstem is responsible for processing cranial nerve sensory information. If you were to see a question like this on step 1, the answer choices would likely be spread out, something like this. You'd have like A, B, C, D, E, and F. As you can see from this question, you don't necessarily need to memorize each nucleus in the brainstem. Simply recognizing what part of the brainstem you're looking at and knowing that the cranial nerve nuclei are near the fourth ventricle is likely sufficient. If you want to take it one step further, remember that sensory nuclei are located laterally, but that really is the extent of what you need to know for step one. So again, because this patient's deficit deals with sensory information, we can deduce that the cranial nerve nucleus that's damaged must be lateral to the sulcus limitans, and because it's on the right side of her tongue, we should know that the answer is A. Again, this is table 8.1 from your text. As we can see, the glossopharyngeal nerve is responsible for taste and general sensation from the posterior 1/3 of the tongue. Okay, let's do another question. What symptoms should you suspect in a patient with a fractured right jugular foramen? In order to get this question right, you need to remember what nerves traverse the jugular foramen and the function of each nerve. Recall that cranial nerves 9, 10, and 11 traverse this jugular foramen, so each of these would be affected in this patient. Because the right jugular foramen is fractured, we'd suspect the patient to have symptoms on the ipsilateral side. Here we have figure 8.23, and we can see that cranial nerves 9, 10, and 11 traverse the jugular foramen, this region right here. From table 8.1, we can see that the patient would experience many symptoms, specifically any symptom associated with damage to cranial nerves 9, 10, and 11. So, for example, the patient may have difficulty swallowing, perhaps abnormalities associated with taste and sensation from the posterior 1/3 of the tongue, perhaps constipation due to loss of parasympathetic input to the abdominal viscera, and also perhaps an inability to elevate the right shoulder. Again, the patient could experience any of the symptoms associated with a deficit involving these three cranial nerves. Okay, let's do another question. A 32-year-old woman with uncontrolled type 1 diabetes presents with sinus pain and tachypnea. Upon further examination, you suspect involvement of the cavernous sinus. What other symptoms would this patient likely have due to involvement of the cavernous sinus? Okay, from the question stem, you should be able to recognize that the patient has a mucor and rhizopus infection. Recall that mucor and rhizopus are opportunistic fungal infections which are commonly associated with diabetic ketoacidosis, or DKA. Because our patient is a type 1 diabetic and is presenting with tachypnea, we can assume she's in a ketoacidotic state, which increases her risk for a mucor and rhizopus infection. It's important to know that mucor and rhizopus can penetrate into the cavernous sinus, resulting in a cavernous sinus thrombosis. Aside from this, the question stem tells us that the cavernous sinus is involved, so we can assume that the cranial nerves traversing this region are damaged. So in order to get this question right, we need to know which nerves traverse the cavernous sinus. Again, this is figure 8.24, which shows a coronal view of the cavernous sinus. As we can see, cranial nerves 3, 4, 6, the ophthalmic branch of the trigeminal nerve, and the maxillary branch of the trigeminal nerve all traverse this region, which means we'd expect the patient to have symptoms associated with damage to these nerves. From table 8.1, we can see that involvement of cranial nerves 3, 4, and 6 would all cause paralysis of muscles of the eye. Involvement of the ophthalmic branch of the trigeminal nerve would result in a loss of facial sensation around the eyes and the forehead. And involvement of the maxillary branch of the trigeminal nerve would result in loss of facial sensation around the maxilla. Okay, let's do another question. A plastic surgeon accidentally cuts the nerve that passes through the left parotid gland. What symptoms will the patient likely experience as a result of the mistake? Okay, for step 1, it's important to know that the facial nerve passes through the parotid gland but doesn't innervate it. Recall that the glossopharyngeal nerve innervates the parotid gland, whereas the facial nerve innervates the sublingual and submandibular glands. So from this example, we can assume that the surgeon accidentally cut the left facial nerve. For step 1, you need to be able to distinguish 3 different lesions of the facial nerve. First, you need to know the symptoms associated with damage to the upper motor neuron. Second, you need to know the symptoms associated with damage to the lower motor neuron. So earlier, we talked about upper and lower motor neuron lesions to the facial nerve, so I'm not going to spend more time on that now. However, we have not talked about the symptoms associated with damage to the peripheral branches of the facial nerve. So the third type of lesion that you need to be familiar with is peripheral lesions. Although many peripheral branches of the facial nerve could be lesioned and produce different symptoms, I believe it's most high yield to remember that once the facial nerve passes through the parotid gland, it only contains motor fibers innervating the face. In this example, we know that the facial nerve distal to the parotid gland was lesioned, so we could assume that all of the functions of the facial nerve would be intact apart from the motor innervation to the face. In this case, the patient would experience complete paralysis of the left side of the face. From table 8.1, we can see that the patient would only experience paralysis of the left side of the face. As I just explained, all of these other functions would be intact. Welcome to part 2 of section 3 in neurology. In the last part of this section, we introduced the cranial nerves and had begun going through some examples. In this section, we'll continue going through important examples to tie all of the information together. Let's get started. When the patient is asked to say ah in an attempt to elevate the palate, the uvula deviates to the right. What cranial nerve shown below is likely damaged? Remember, the vagus nerve normally innervates the muscles of the soft palate, which helps elevate that side of the mouth and keep the uvula midline. When the vagus nerve is damaged, the ipsilateral palate can no longer be elevated, which results in unopposed elevation of the opposite side when the patient says ah. In other words, damage to the vagus nerve results in deviation of the uvula to the opposite side. So damage to cranial nerve 10 results in contralateral deviation of the uvula. From the question stem, we can see that the patient's uvula deviates to the right, which must mean the left vagus nerve is affected. With this in mind, we need to be able to identify the vagus nerve from this anterior view of the brainstem. Because we're looking at an anterior view of the brainstem, we can deduce that this is the right side and this is the left side. In this case, we can see the left vagus nerve right here. If we look at figure 8.22 again, we can see all of the cranial nerves labeled. Again, this is figure 8.22. We can see the vagus nerve is right here. From table 8.1, we can see that the vagus nerve is responsible for elevating the soft palate and keeping the uvula midline. Okay, let's do another question. A 65-year-old female presents to the neurologist with numbness of the anterior tongue with taste intact and difficulty chewing food. The damaged nerve passes through which foramen of the skull? Okay, because this patient has numbness of the anterior part of the tongue and difficulty chewing food, we can deduce that the mandibular branch of the trigeminal nerve must be affected. So, V3. As we can see from table 8.1 from your text, the mandibular branch of the trigeminal nerve is responsible for sensation around the mandibles, sensation of the anterior 2/3 of the tongue, as well as muscles of mastication. It's important to remember that taste of the anterior part of the tongue is innervated by the facial nerve and not the mandibular branch of the trigeminal nerve. Again, this is sensation of the anterior 2/3 of the tongue, but not taste. From figure 8.23, we can see that the mandibular branch of the trigeminal nerve passes through the foramen ovale. So this region right here. So again, from the question stem, we should notice that sensation from the anterior tongue is damaged and that the patient has difficulty chewing food. Both of these symptoms should make us think of damage to the mandibular branch of the trigeminal nerve. And then we need to recall that this nerve traverses the foramen ovale. Okay, let's do another question. A patient presents with deviation of the left eye toward the midline when asked to look straight ahead. The neurologist suspects a tumor compressing which region of the brain? So the right eye is not mentioned, so we can assume it's unaffected. But the left eye deviates medially, like this. Again, right eye is unaffected. Recall that the abducens nerve innervates the lateral rectus muscle, which is responsible for moving the eye laterally. If the abducens nerve is damaged, then the medial movement of the eye is no longer counterbalanced by the force of the lateral rectus, so the eye will tend to move medially. So in this case, the lateral rectus is affected, which means the abducens nerve must be affected, which again is cranial nerve 6. And recall that cranial nerves 5 through 8 emanate from the pons. In this case, we're asked which region of the brain is being compressed by a tumor, so the answer is the pons. From table 8.1, we can see that the abducens nerve normally provides motor output to the lateral rectus. Okay, let's do another question. A newborn has a cleft upper lip secondary to Patau syndrome. The nerve that innervates this region passes through which foramen of the skull? It's not particularly pertinent to get this question right, but recall that Patau syndrome is a disorder caused by an extra chromosome 13, so trisomy 13. And this results in several abnormalities, including a cleft lip. In order to get this question right, we need to remember what nerve innervates the upper lip. Remember, the upper lip is innervated by the maxillary branch of the trigeminal nerve. From table 8.1, we can see that the maxillary branch of the trigeminal nerve provides facial sensation around the maxilla. This would include the upper lip. From figure 8.23, we can see that the maxillary branch of the trigeminal nerve passes through the foramen rotundum. Okay, let's do another question. When a patient is asked to look to the left eye moves laterally and the right eye moves medially and slightly superior. What part of the brainstem is likely involved? Okay, let's draw this out to see what's happening. This will represent the patient's right eye, and this will represent the patient's left eye. From the question stem, we can see that when looking left, the left eye moves laterally. So let's show that here. When looking left, the left eye moves laterally. The right eye moves medially, as expected, but also slightly superior, which is unexpected. So like this. These clinical findings should make you think of damage to the trochlear nerve. Recall that normally, the trochlear nerve innervates the superior oblique muscle. If we draw an eye that's normal over here, we can see that the superior oblique muscle normally inserts on the eye at an angle, like this. It can be somewhat difficult to visualize, but this muscle normally causes the eye to move downward, like this, as well as intort, or internally rotate, like this. This means when the trochlear nerve is damaged, the eye has a difficult time moving downward and internally rotating. This is also why when the patient is asked to look to the left, the right eye moves slightly upward. Normally the eye movement is balanced by muscles pulling upward and downward, so a loss of the superior oblique muscle will result in an excessive upward force. Examiners commonly like to mention that the patient has difficulty going downstairs or reading because these actions commonly involve looking down. Okay, so we know that the trochlear nerve is damaged, but the question is asking what part of the brainstem is likely involved. In order to get this question right, we need to recall that cranial nerves 3 and 4 emanate from the midbrain. So in this case, the midbrain is likely involved. Again, this is table 8.1 from your text, which tells us that the trochlear nerve provides motor output to the superior oblique muscle. Okay, here's another question. How would damage to the facial nerve alter hearing? Recall that the facial nerve normally innervates the stapedius muscle, which helps stabilize the stapes bone. In other words, the facial nerve innervates the stapedius muscle, which dampens sound. So the facial nerve normally innervates the stapedius muscle, which dampens sound. When de-innervated, the stapedius muscle loses its control on the stapes bone, such that the bone can oscillate more forcefully, causing the patient to experience sensitivity to sound, or hyperacusis. As we can see, damage to the facial nerve would result in hypersensitivity to sound. From table 8.1, we can see that the facial nerve is normally involved in modulating sound. And again, that is through the stapedius muscle. Okay, let's do another question. An MRI shows a fracture of the right hypoglossal canal. What symptoms would be present in the patient? Recall that the hypoglossal nerve traverses the hypoglossal canal. Damage to this nerve results in ipsilateral tongue deviation. Normally, the muscles innervated by the hypoglossal nerve help stick the tongue out like this. So here's the tongue. They normally help the tongue move out like this. In this question, the right hypoglossal nerve is damaged, which means the right side of the tongue is paralyzed. Right, left, right is paralyzed. This means the actions of the muscles on the left side of the tongue are unopposed, which will cause the tongue to deviate to the right. Some students use the mnemonic, "the tongue licks the wound," to help them remember that when the hypoglossal nerve is damaged, the tongue deviates to the same side that was damaged. Again, from table 8.1, we can see that the hypoglossal nerve is normally responsible for moving the tongue. From figure 8.23, we can see that the hypoglossal nerve normally traverses the hypoglossal canal. Okay, let's do another question. 1 month ago, a 23-year-old male developed a ring-like rash after hiking in the Appalachian Mountains. He presents to the emergency department today due to complete paralysis of the right side of his face. What region of the brain is likely involved? From the question stem, hopefully you picked up on the fact that this patient has Lyme disease. Recall that Lyme disease is caused by a microbe called Borrelia burgdorferi, which is commonly transmitted by the Ixodes deer tick, which is prevalent in the northeastern United States. Stage 1 of Lyme disease commonly results in a ring-like rash. This rash is called erythema migrans, which our patient had after hiking through the Appalachian Mountains. Stage 2 of Lyme disease can result in facial nerve palsy. For step 1, it's important to know that Lyme disease results in damage to the lower motor neuron of the facial nerve, which results in complete paralysis of the ipsilateral face. Let's draw this out again to remind you of the unique neural pathway of the facial nerve. This will represent the facial nucleus in the pons, which contains an upper component, so U for upper, and lower component, L for lower. The upper component receives innervation from both cerebral cortices, whereas the lower component only receives innervation from the contralateral cortex. Let's draw this out. So again, as you can see from this image we've just drawn, the upper component receives dual innervation, whereas the lower component only receives innervation from the contralateral cortex. It's important to know that the upper component of the facial nucleus innervates the superior aspect of the face. So this will represent the face, and the upper component innervates the upper face, whereas the lower component innervates the lower face. So again, Lyme disease results in damage to the lower motor neuron of the facial nerve, which means both the upper and lower components of the facial nucleus would be damaged. As we can see from this pathway, damage to the right facial nucleus would result in complete paralysis of the right side of the face. This is figure 8.25 for your review, which illustrates the facial nerve pathway we just discussed. So again, the question is asking about what region of the brain is likely involved. As I just showed, the facial nucleus is damaged due to Lyme disease, which means the pons must be involved. Recall that cranial nerves 5 through 8 emanate from the pons, so in this case, we can assume that the pons must be involved. Okay, let's do one more question. A 26-year-old male presents to the emergency department after an automobile accident. Upon examination, the physician notices several abnormalities of the right eye, including ptosis, mydriasis, and an inability to look to the left. What foramen of the skull was likely fractured? From the symptoms provided, we should be able to deduce that the patient has damaged cranial nerve 3, or the oculomotor nerve. From table 8.1, we can see that damage to the oculomotor nerve would result in ptosis or drooping of the eyelid, because the oculomotor nerve normally assists with eyelid elevation. We'd also expect the right pupil to be dilated or to experience mydriasis because the oculomotor nerve normally causes pupillary constriction. Finally, we expect the patient to be unable to look medially because the medial rectus is damaged. So again, from the question stem, we can see that the patient has abnormalities affecting the right eye, including ptosis, mydriasis, and an inability to look to the left, which should make us think of damage to the oculomotor nerve. From figure 8.23, we can see that the third cranial nerve traverses the superior orbital fissure. So the right superior orbital fissure was likely fractured, resulting in damage to the right third cranial nerve. So again, this patient has ptosis, mydriasis, and an inability to look to the left. This is all occurring in the right eye, which should make us think of damage to the right oculomotor nerve. So cranial nerve 3, and again, this nerve traverses the superior orbital fissure.
Welcome to section 4 of neurology. In this section, I will be discussing the hypothalamus, thalamus, and the limbic system. Let's get started. This is figure 8.3 from your text, which is a mid-sagittal view of the brain. Again, this is anterior, and this is posterior. In this image, we can clearly see the thalamus right here, and we can also see the hypothalamus. Let's talk about the thalamus first. This is table 8.2 from your text, which shows the highest yield information relevant to the thalamus. We've covered or will cover all of these pathways throughout the various sections in this chapter, so I'm not going to spend time mapping out each of these pathways right now. However, this table is a good summary of the pathways that interact with the thalamus, and you will need to know all of this information for step 1. This is table 8.3, which shows the hypothalamic nuclei and their corresponding functions. For step 1, you need to know the names of each hypothalamic nucleus and its associated function. Again, I'm not going to read this table to you, but you do need to memorize this information for step 1. I recommend that you pause the video and take some time to memorize both of these tables if you're unfamiliar with this information. Okay, before we jump into some of the questions, let's briefly discuss the limbic system. This is figure 8.4 from your text, which is a lateral view of the limbic system and the basal ganglia. This figure is especially helpful in viewing some of the structures of the limbic system. The limbic system includes many structures, including the hippocampus, the amygdala, the mammillary bodies, the fornix, the cingulate gyrus, and others. However, for step 1, it's most important to be familiar with the hippocampus, the amygdala, and the mammillary bodies. For step 1, you need to know that both the mammillary bodies and the hippocampus are associated with memory. However, the main cause of damage to the mammillary bodies is thiamine deficiency. On the other hand, if the question stem doesn't mention thiamine deficiency, then the hippocampus was most likely damaged. It's also important to know that the hippocampus is highly susceptible to damage under hypoxic conditions. So again, if you get a question about issues with memory, it should make you think of problems with the mammillary bodies or the hippocampus. If the question stem refers to thiamine deficiency, then you should think of damage to the mammillary bodies. However, if the question stem doesn't mention this, or it also mentions some hypoxic incident, then you should think of damage to the hippocampus. Okay, moving on to the amygdala. The amygdala is associated with emotions and decision-making. For step 1, you need to know that bilateral damage to the amygdalas results in hyperorality, hyperphagia, and hypersexuality. And this is a syndrome called Kluver-Bucy syndrome. Okay, let's see what your text says. So again, the mammillary bodies and the hippocampus are associated with memory. And if you get a question about thiamine deficiency, you should think of damage to the mammillary bodies. And if you get a question about hypoxia and memory loss, you should think about damage to the hippocampus. The amygdala is associated with emotions and decision-making, and bilateral damage to the amygdalas results in hyperorality, hyperphagia, and hypersexuality, which is a syndrome called Kluver-Bucy syndrome. Okay, let's wrap up this section with a few questions. Researchers are studying a hypothalamic nucleus that may be damaged in patients with Prader-Willi syndrome. What nucleus are the researchers most likely studying? So the question stem mentions Prader-Willi syndrome. Recall that Prader-Willi syndrome is caused by a deleted or mutated portion of chromosome 15 that should normally be passed on by the father. Let's draw this out. The maternal region of chromosome 15 is normally silenced. So 15 is silenced. And the paternal region of chromosome 15 is normally passed on to the child. So this is normal. As you can see, the maternal portion of this chromosome is normally silenced, so the baby must get this region of chromosome 15 from dad, or the baby will develop Prader-Willi syndrome. In this example, our patient has Prader-Willi syndrome, so we can assume that he has a silenced 15 from mom, and then a defective 15 from dad. So again, dad's chromosome is defective. In order to get this question right, you need to recall that symptoms associated with Prader-Willi syndrome include hyperphagia and obesity. This question is asking about what hypothalamic nucleus may be involved in this disorder. Recall that the ventromedial nucleus of the hypothalamus normally mediates satiety, or a sense of fullness. So if this nucleus is damaged, then patients will constantly feel hungry and overeat. So again, the ventromedial nucleus of the hypothalamus normally causes satiety. So you can imagine if this is damaged, then patients will constantly feel hungry. And because our patient is overeating, we can assume that the researchers are most likely studying the ventromedial nucleus of the hypothalamus. So the ventromedial nucleus. From table 8.3, we can see that the ventromedial nucleus normally mediates satiety. So damage to this region of the brain would result in hyperphagia, as I just showed. Okay, let's do another question. A 72-year-old female presents with loss of proprioception, vibration, temperature, and pain on the left side of her body. What thalamic nucleus is likely damaged? Okay, so in order to get this question right, you need to be familiar with the tracts that convey proprioception, vibration, temperature, and pain. Recall from section 2 that the spinothalamic tract, ST for short, conveys information about pain and temperature, and that the dorsal column, so DC for short, conveys information about proprioception and vibration. Both of these pathways synapse on the ventral posterolateral nucleus, or the VPL. In this case, we can assume that the VPL must be damaged because information from both tracts are affected. Because both of these pathways decussate or cross over to the opposite side of the body, we can assume that the right VPL must have been damaged. So again, the right VPL was likely damaged. From table 8.2, we can see that both the spinothalamic and dorsal column tracts convey their information to the ventral posterolateral nucleus of the thalamus. If this example was confusing, I encourage you to go back to section 2 and watch the videos about the spinal tracts. The goal here is not to focus on the spinal tracts, but the nuclei of the thalamus. Okay, let's do another question. A 28-year-old homeless man presents to the emergency department after being mugged. He repeatedly asks where he is and seems confused. Upon exam, you notice complete paralysis of the eyes. What region of the brain is likely damaged? Hopefully you notice several key components from the question stem. Our patient is homeless. He has memory problems, so we can see because he repeatedly asks questions, and he has ophthalmoplegia, or paralysis of the eyes. This description should make you think of alcohol abuse resulting in vitamin B1 or thiamine deficiency. Recall that thiamine deficiency can result in a syndrome called Wernicke-Korsakoff syndrome. This syndrome results in several symptoms including memory loss, ophthalmoplegia, personality changes, and others. It's high yield to remember that in this syndrome, the mammillary bodies are damaged, and this explains the memory loss and the confusion. So again, the mammillary bodies are most likely damaged because this patient has thiamine deficiency. From figure 8.4, we can see the mammillary bodies right here. Okay, let's do one more question. A 24-year-old man recently returned from his first trip to Mount Everest. During his ascent, he became injured and lost several liters of blood. Since returning, he has had difficulty forming new memories. What region of the brain was likely damaged? So unless the question stem alludes to damage to the mammillary bodies, as we saw with the last example, memory loss should make you think of damage to the hippocampus. So we know that this patient has had difficulty forming new memories, and there's no sign of thiamine deficiency, so we should immediately think of damage to the hippocampus. Also recall that the hippocampus is highly susceptible to damage under hypoxic conditions. Because this patient was at high altitude, which we know because he was climbing Mount Everest, and we know that he lost several liters of blood, we can assume that he experienced severe hypoxia. So again, hypoxia results in damage to the hippocampus, which results in an inability to form new memories. Again, from figure 8.4, we can see the hippocampus right here. And that concludes this section.
Welcome to the second part of section 9. In this video, I'll focus on examples associated with the neurovasculature, which should be helpful in applying and integrating the material. Let's get started. Okay, the first question. A 68-year-old right-handed woman presents with right-sided facial paralysis, sparing the forehead, and paralysis of the right upper limb. Rupture of an aneurysm likely occurred near what vessel? Okay, from the question, we know that the patient has right-sided facial paralysis, sparing the forehead, and paralysis of the right upper limb. These symptoms should immediately make you think of the homunculus and its vascular supply. Let's pull up the homunculus so you can more clearly see what's happening. This is figure 8.6, which shows the homunculus. From this image, we can see that our patient has damaged this region of the homunculus because we know that the patient is experiencing paralysis of the upper extremity and the face. Recall that the lateral portion of the precentral gyrus is supplied by the middle cerebral artery, or MCA. The question asks about rupture of an aneurysm, so with this information, we can deduce that an aneurysm originating from the MCA must have ruptured. Because this patient has right-sided paralysis, and we know that the corticospinal tract decussates, we can deduce that the left MCA must be affected. Also note from the question stem that the patient had facial paralysis, but that the forehead was spared. This is because a lesion to the cortex would cause paralysis of the inferior aspect of the face, whereas a lesion to the facial nucleus in the pons would cause complete paralysis of the face. We cover this in more detail in section 3, so go review that if you're confused. This is table 8.5, which provides a list of clinically relevant aneurysms and the associated lesioned area and symptoms. From this table, we can see that rupture of an aneurysm in the MCA results in a stroke of the MCA distribution, resulting in identical symptoms to that of an MCA stroke, which is contralateral paralysis and sensory deficits of the face and upper limb. Okay, let's do another question. A 65-year-old right-handed male with a history of diabetes and a previous myocardial infarction presents with sudden loss of vision. Fundoscopy shows a cholesterol embolus. From what major branch of the circle of Willis did the embolus most likely originate? Okay, from the question stem, we know that the patient has vision loss, and fundoscopy shows a cholesterol embolus. We also know that the embolus came from the circle of Willis. Recall that the ophthalmic artery is a branch of the internal carotid artery, so the embolus must have originated from the internal carotid artery. Let's pull up an image so you can see what's going on. This is figure 8.46, which provides a general overview of the neurovascular anatomy. From this image, we can see the ophthalmic artery right here. Notice how this artery is a direct branch of the internal carotid artery, this region right here. So again, the embolus most likely originated from the internal carotid artery. Okay, here's another question. An 80-year-old right-handed male presents with paralysis of the right lower extremity. What vessel shown below is most likely occluded? In order to get this question right, you need to be familiar with the circle of Willis and the vascular supply of the precentral gyrus. Recall that the anterior cerebral artery, or ACA, supplies blood to the lower extremities. Because our patient has paralysis of the right lower extremity, or right leg, we can deduce that the left ACA must be occluded. From this figure, the left ACA is right here. From figure 8.6 of the homunculus, we can clearly see that our patient has damaged this region. This is because we know that the patient is experiencing paralysis of the lower extremity. Again, the medial portion of the precentral gyrus is supplied by the anterior cerebral artery, or ACA. Because this patient has right-sided paralysis, and we know that the corticospinal tract decussates, we can deduce that the left ACA must be affected. So again, the left ACA must be occluded, which is right here. From table 8.4, we can see that an occlusion of the anterior cerebral artery results in damage to the medial aspect of the primary sensory and motor cortices. This results in contralateral motor and sensory deficits of the leg. Okay, next question. A 67-year-old right-handed male presents with a blood pressure of 210/170 and left-sided paralysis and sensory loss. Imaging shows hyperintensities near the striatum. What vessel is most likely damaged? Okay, so hypertension and damage to the striatum should immediately make you think of the lenticulostriate arteries. Recall that chronic hypertension is highly associated with Charcot-Bouchard microaneurysms of the lenticulostriate arteries. So again, because this patient has an extremely high blood pressure, and we know that there are hyperintensities near the striatum, we can deduce that this patient most likely has damaged the lenticulostriate arteries. From figure 8.49, we can see that damage to the lenticulostriate arteries would result in ischemia to the internal capsule and basal ganglia. If the internal capsule becomes damaged, we'd expect the patient to develop contralateral paralysis and sensory deficits. This is because the corticospinal, corticobulbar, and corticothalamic tracts pass through the internal capsule and then decussate. From the question stem, we know that the patient presented with left-sided paralysis and sensory loss. Again, because the tracts decussate, we'd expect the right internal capsule to be damaged. So in this case, we can deduce that the right lenticulostriate arteries must be damaged. If the basal ganglia becomes damaged, we'd expect the patient to develop movement abnormalities, but this would be hard to predict unless more information was given about what part of the basal ganglia was damaged. From table 8.4, we can see that damage to the lenticulostriate arteries would result in contralateral paralysis and sensory deficits of the entire body. And again, the basal ganglia would also likely be damaged, which would result in movement abnormalities, but those would be hard to predict. Okay, let's do another question. A 77-year-old right-handed male presents with left-sided hemiparesis, loss of vibration and proprioception on the left side, and right-sided tongue deviation. What vessel is likely occluded? One of the most prominent clues of this question is right-sided tongue deviation. We've only learned about one vessel that, when occluded, can result in damage to the hypoglossal nucleus, which can cause tongue deviation. Recall that the anterior spinal artery, or ASA, supplies blood to this region, which explains the patient's deviated tongue. Remember from section 3 on cranial nerves that damage to the hypoglossal nucleus results in tongue deviation to the ipsilateral side, so we can deduce that the right ASA must be occluded. Let's pull up some images to review the patient's symptoms. On this slide, we have figure 8.20 showing a transverse section of the medulla. Recall from part 1 of this section that the paramedian branches of the ASA supply blood to approximately this region right here. As we can see, the hypoglossal nucleus is right here, and because this nucleus is so medial and deep, it can become ischemic during an occlusion of the ASA or the paramedian branches of the ASA. Also notice how the medial lemniscus and the corticospinal tracts are both medial and receive blood directly from the paramedian branches of the ASA, so these are also affected. From figure 8.13, we can see that the dorsal columns ascend through the medial lemniscus and are responsible for vibration and proprioception. So damage to the medial lemniscus
right here, in an ASA stroke would result in contralateral loss of vibration and proprioception. In this case, we know that the right medial meniscus was damaged, which explains the patient's loss of vibration and proprioception on the left side of the body. From figure 8.15, we can see that the corticospinal tract descends through the anterior pyramids, so damage to the anterior medulla in an ASA stroke would result in contralateral paralysis. In this case, we know that the right pyramid became ischemic, which explains why the patient has left-sided paralysis. Okay, let's do another question. A 67-year-old right-handed male with a history of diabetes mellitus and multiple myocardial infarctions presents with a 2-week history of progressive bilateral upper and lower limb paralysis and bilateral loss of pain and temperature. Proprioception and vibration are intact bilaterally. What vascular territory is likely ischemic? Okay, hopefully from the question stem you gathered that this patient has a history of atherosclerosis. We also know some part of the corticospinal tract is disrupted because this patient has bilateral paralysis. Likewise, we know that some part of the spinothalamic tract is disrupted because the patient has bilateral loss of pain and temperature. Perhaps most importantly, we know that the dorsal columns are unaffected because the question stem states that proprioception and vibration are intact bilaterally. Hopefully all this information has made you think of ischemia to the vascular territory supplied by the anterior spinal artery, or ASA ischemia. Let's pull up an image so you can more clearly see what's going on here. This is figure 8.9, which shows a cross-section of the spinal cord. Again, this is anterior and this is posterior. Recall that after the ASA descends past the medulla, it supplies blood to approximately this region here. Notice how this vascular territory supplies the anterior and lateral aspects of the spinal cord, but spares the dorsal columns. Widespread atherosclerosis can result in ischemia to the ASA and the anastomosing branches that feed the ASA, resulting in ischemia to the area I've outlined here. In this case, the blood supply is compromised, resulting in damage to the corticospinal tracts, which explains the bilateral paralysis, the spinothalamic tracts, which explains the bilateral loss of pain and temperature, and as we can see, the dorsal columns are spared, which explains why proprioception and vibration are intact bilaterally. So again, the vascular territory supplied by the ASA is ischemic due to widespread atherosclerosis. Okay, let's do another question. A 52-year-old right-handed male with a history of coronary artery disease presents with vertigo, ataxia, dysphagia, and difficulty speaking. What vessel is most likely occluded? Recall from part 1 of this section that dysphagia and dysphonia, or difficulty speaking, are unique to lateral medullary syndrome. Lateral medullary syndrome is caused by damage to the posterior inferior cerebellar artery, or pica. Let's pull up some figures to make this clearer. From figure 8.46, we can see that the pica is right here. Again, notice how the pica wraps around the lateral aspect of the medulla, hence the name lateral medullary syndrome. It's important to know that lateral medullary syndrome can also be caused by damage to the vertebral artery. This is because the pica is a direct branch of the vertebral artery, which we can clearly see from this image. So on the last slide, I said the answer was damage to the pica, but if you thought of the vertebral artery, you'd also be correct. From figure 8.20, which shows a transverse section of the medulla, we can more clearly identify the structures that would be damaged in lateral medullary syndrome. Again, this is anterior and this is posterior. And the pica supplies blood to the lateral medulla, or approximately this region here. Recall from part 1 of this section that it's most important to remember that the nucleus ambiguus is damaged in this syndrome. Recall that the nucleus ambiguus contains motor information from cranial nerves 9 and 10. From section 3, recall that cranial nerves 9 and 10 provide motor output to the pharynx and larynx, so damage to these structures would result in dysphagia and dysphonia. Also notice that the vestibular nuclei are right here, so damage to these nuclei explains the patient's vertigo. The patient also has ataxia, which can be explained by damage to the inferior cerebellar peduncle right here. From table 8.4 and this image, the patient also could have presented with a number of other symptoms. However, in order to have gotten this question correct, you needed to recall that dysphagia and dysphonia are unique to lateral medullary syndrome. Again, this is due to damage to the nucleus ambiguus. From table 8.4, we can see that damage to the posterior inferior cerebellar artery or the vertebral artery can both result in lateral medullary syndrome. On the right, we have a list of structures that are compromised and the corresponding symptoms. Okay, let's do another question. A patient presents with Horner syndrome, nystagmus, right-sided facial paralysis, and taste deficits. What vessel is most likely occluded? Recall from part 1 of this section that facial paralysis and taste deficits are unique to lateral pontine syndrome. Lateral pontine syndrome is caused by damage to the anterior inferior cerebellar artery, or AICA. Let's pull up some figures to make this clear. From figure 8.46, we can see that the AICA is right here. Again, notice how the AICA wraps around the lateral aspect of the pons, hence the name lateral pontine syndrome. From figure 8.18, which shows a transverse section of the pons, we can more clearly identify the structures that would be damaged in lateral pontine syndrome. Again, this is anterior and this is posterior. The AICA supplies blood to the lateral pons, or approximately this region here.
For this syndrome, it's most important to remember that the facial nucleus and the solitary nucleus are damaged. Damage to the motor aspect of the facial nucleus will result in total ipsilateral facial paralysis. Recall that the solitary nucleus contains sensory information from cranial nerves 7, 9, and 10. So knocking out the sensory aspect of the facial nerve would result in taste deficits from the ipsilateral anterior two-thirds of the tongue. On the other hand, knocking out sensory aspects of cranial nerves 9 and 10 would result in more vague symptoms, which we explained in part 1 of this section. So again, facial paralysis and taste deficits from the anterior two-thirds of the tongue are symptoms unique to lateral pontine syndrome. Also notice that the vestibular nuclei are right here. So damage to these nuclei explains the patient's nystagmus. The patient also has Horner syndrome, which can be explained by damage to the descending sympathetic fibers from the hypothalamo-spinal tract in the lateral tegmentum, which is about right here. From table 8.4 and this image, the patient also could have presented with a number of other symptoms. However, in order to have gotten this question correct, you needed to recall that facial paralysis and taste deficits are unique to lateral pontine syndrome. Again, this is due to damage to the facial nucleus and the solitary nucleus. From table 8.4, we can see that damage to the anterior inferior cerebellar artery results in lateral pontine syndrome. On the right, we have a list of structures that are compromised and the corresponding symptoms. Okay, let's do another question. An 88-year-old right-handed female presents with quadriplegia and bilateral facial paralysis. An astute medical student notices that the patient has the ability to respond by blinking. What vessel is most likely occluded? Recall from part 1 of this section that complete paralysis and facial paralysis with the ability to blink is unique to locked-in syndrome. Also recall that locked-in syndrome is caused by damage to the basilar artery. Let's pull up some figures to make this clear. From figure 8.46, we can see that the basilar artery is right here. Again, notice how the basilar artery is a midline vessel that supplies blood to the medulla, pons, and the midbrain. Because so much of the anatomy is affected in this type of lesion, I find it most helpful to focus on the structures that are spared. In order to see this, let's focus on the midbrain. This is figure 8.16, which is a cross-section of the midbrain. This is anterior, and this is posterior. From the last image, we know that the basilar artery is about right here. The branches of the basilar artery dive deep into the brainstem, so much of the anatomy in the midbrain is damaged. However, the oculomotor nerve right here is one of the deeper structures of the midbrain and is typically not damaged during occlusion of the basilar artery. This is why patients can blink and move their eyes vertically. The reticular formation and the tegmentum are also spared, which explains why the patient has preserved consciousness. Recall from part 1 of this section that the reticular formation is a group of many nuclei throughout the brainstem, so it can't be easily identified on one image like this. The tegmentum is also a general area within the brainstem, but on this section of the midbrain, it's located throughout this region about right here. Again, preservation of the reticular formation and the tegmentum explains why the patient has preserved consciousness. From table 8.4, we can see that damage to the basilar artery results in locked-in syndrome. On the right, we have a list of structures that are compromised and the corresponding symptoms. But again, I find it most helpful to recall those structures that are not damaged, which is shown right here. Okay, let's do another question. A 26-year-old right-handed male presents with abnormalities of the right eye, including mydriasis, ptosis, and difficulty adducting the eye. An aneurysm from what vessel is most likely responsible for the patient's symptoms? Recall from part 1 of this section that mydriasis, ptosis, and difficulty adducting the eye are unique symptoms associated with damage to the oculomotor nerve, or cranial nerve 3. Remember, an aneurysm originating from the posterior communicating artery, or PCOM, can compress the oculomotor nerve, resulting in the symptoms described in this vignette. Let's pull up some figures to make this clear. From figure 8.47, we can see the posterior communicating artery right here. Recall that the oculomotor nerve passes between the superior cerebellar artery and the posterior cerebral artery as it projects anteriorly like this. This means that an aneurysm originating from the PCOM right here could compress the oculomotor nerve, resulting in the symptoms described in this vignette. From table 8.5, notice that an aneurysm originating from the PCOM can compress the superficial parasympathetic fibers of cranial nerve 3, resulting in mydriasis and ptosis, and compression of the deep somatic fibers of cranial nerve 3 can result in paralysis of the corresponding ocular muscles.